Hi everyone, Dr. Demito here. I wanted to create a presentation to briefly go over the concept of differential diagnosis. This is something you're going to see more and more as you progress throughout the program. And the differential diagnosis is key. So what is it? Well, I like to, and I say this in almost every one of my videos, I like to put uh, the development of a diagnosis and differential diagnosis in the same category as an investigation. So that's exactly what we're doing. We're taking all of the clues that we gather through the patient, what the patient tells us, what we see, laboratory results, and we take all of those things and we create a list of what is the most probable cause for the condition. Now, the very first one that we come up is the presumptive diagnosis. So that's the one that most likely fits the majority of all criteria. And we list those in order. This is something that you'll be doing a lot of in NP school. And you do it more in your head when you're a practitioner. But it's very, very important to understand these concepts. So that's the emphasis of this presentation today. So essentially what I said, generating a differential is creating that list using all of the tools and information that you gather in your patient visit. And it's important to do so not only so that we're ensuring that we are providing the patient with the best possible care, but courts also consider the formulation and documentation as prudent evidence that you are a competent practitioner. So always when you are in the healthcare field, we have to consider the legal liability of our actions. And so creating a differential diagnosis really can help with that. And as we are defining what our differential is, there are some aspects we need to identify. And so we have to be able to recognize that there is a collection of signs and symptoms. We need to have a basic understanding of the pathophysiology that goes along with that disease process, restate in terms of a disease, reconnect with the initial complaint, and then reframe, considering diagnosis when there is a progression of unusual natural history. Okay, so let me take an easy one. You guys are really early in on the program. Let's take an easy one. The patient presents as a 13-year-old with sore throat, swollen glands, fever, and okay, so I take all of that and I say, you know what, I bet you that, from a sore throat, fever, swollen glands, I bet he has strep. But I can't leave it at that. I have to consider what else could it be. Well, it could be, does he have a headache? Could he have in a stiff neck? Could it be meningitis? Could it be mono? So I have to consider all of those what ifs when I am coming to my diagnosis. Now, of course, I can do a point of care test and identify whether or not he has strep pretty readily, but you need to also understand what the other things could be. So that's really important to have that grasp of understanding of the what ifs. Now, many diagnostic errors occur because we try to fit the data into the hypothesis rather than fitting the hypothesis into the data, okay? So I say, all right, the patient has a sore throat and a negative strep test. He has some swollen glands, but I'm pretty confident that this is strep. So I'm going to call it strep, even though the point of care test says not, because he has so many of the other symptoms that go around with that. And that's what we don't want to do. We don't want to say, oh, the patient has a stomach ache, they probably have gastritis. No, I am of the understanding, or I take the idea that we always consider worst case scenario. So I'm thinking, all right, I'm going to consider first worst case scenario and rule that out. And that's important because errors do occur where we overlook that worst case scenario patient. So when we've eliminated all the impossible whatever remains, however improbable, must be the truth. Okay. So whenever I have a patient who comes in and presents with a headache and sore throat, I always do the diagnostic test, and you'll see when you get into advanced health assessment, I always do the test to rule out that that it is meningitis. And I document that I've done these tests. They're very simple. You don't need any tools. It's just things that the patient does. But I always want to document that just to illustrate that I have considered that diagnosis and I have ruled it out. Now let's look at a case. I think sometimes when we use actual case studies, you can see things a little bit better. Now all of the cases that I get are true. They're all real cases, and I get them off of NSO, which is a malpractice company, and they present cases on their website in hopes to provide learning for providers. So let's look at this one. First one. We have an obese Caucasian male, hypertension and smoking, has severe lower back pain for 4 days. The back pain is accompanied by some occasional vomiting. It radiates intermittently to both lower quadrants of the abdomen. The increased severity of back pain actually woke him up, and he's going to see his provider. His vital signs are normal except a mild elevation of the systolic pressure. The NP assesses the patient, finds no significant physical abnormalities. Femoral pulses are strong and symmetrical. A flat plate x-ray of the abdomen is read and later confirmed as normal, and the CBC is normal as well. Okay, so let's consider this patient. What could it be? How do I decide? Now, if this is a patient that you are working with in one of your courses, whether it be a standardized patient or a patient case study that you're doing, consider these resources. You can use the Touro Library website. Medline, I really like Medline. I use it. It's free and it's very extensive. It's quite comprehensive. A physician friend of mine is the one who introduced me to the Medline app. Epocrates, I like. It's not super expensive. I think it's $100 a year. I use it in practice because it is, it tells me what I need to know. A lot of providers use UpToDate. Personally, that's not my favorite choice. And I'm not saying anything against it. It's a great app, but it gives me too much information. Maybe for a student if you need to know more, but as a provider, it's a little too much for me, and it's expensive. So those are some of the things you need to consider. So with this patient, I'm going to consider musculoskeletal strain, pancreatitis, perhaps even a kidney stone. Kidney stones will react like that as well. So the lessons that we learned. A leaking AAA can mimic renal colic and mechanical back pain, diverticulitis, and gastroenteritis. A AAA might be considered and should be considered in an older patient with symptoms of renal colic. Radiating pain is a common symptom of AAA, and a patient with persistent symptoms should warrant a new evaluation. So we can't always just brush off our patient. We should never do that. We should make our differential diagnosis, and I always tell my patient when I have given them their diagnosis is that they should never feel worse than they do today. If for any reason the symptoms do not appear to be improving, or if at any time they get worse, they need to seek immediate emergency medical treatment. And that is my standard I say that with every patient, and lawyers love me because I have that specific standardization. So if I ever had to go to court and they would say what's included in my discharge instructions, and I said my discharge instructions, and they'd say, well, how do you know that you said it with this particular patient? I would say, because I say it with every one of my patients. So those are some things that you are going to have to consider as a new provider. Patients with pain require analgesia, even if appropriate doses of narcotics control the patient's pain. And we're very, very careful. We're very, very judicious with narcotic pain relief today. And we have found that there are many things, this must be a little bit of an older case, that there are many interventions that we can use where we may not need narcotics. But if the pain's increasing or not getting worse, that's a red flag. So history taking and illegal action, peer experts are going to be critical if there's insufficient information. So this is in the history. And we're going to talk about this in another video that I'm going to put together. Maybe not in this course, but it talks about how to excuse me, how to create an excellent patient history and to identify red flags. And so writing an appropriate note on a patient is very, very important. And utilizing the proper structure is also very important. So these are all tasks that you're going to be learning over the next weeks and months. A physical exam, that's part of our assessment process. We do a physical assessment, we do a physical examination, and then assessment and plan. Those four pieces are components of what we call SOAP notes, and providers utilize the SOAP note method to document their patients. And again, I'll be taking you along this journey of SOAP note documentation as you get further along, but right now I want you to really focus on differential diagnosis. And again, this is the list of what ifs. If a serious diagnosis comes to mind, you have to consider, do we need to test for it, or should I refer this patient? I know for me personally, when I was a new provider, I think I referred a lot more patients than I needed to. But once you begin to feel more comfortable in your setting and in your role, I rarely refer anybody out unless they absolutely require it. Rule out that worst case scenario and discuss the possible diagnoses with your supervisor. What does this mean? So as a new nurse, as a student nurse practitioner, you may want to consider discussing differential diagnoses that you have had, that you're developing with your preceptor. So you got a little ways before you get there. But when you do get to that point, you're definitely going to have conversations with your preceptor about what differential diagnosis they came up with, what you came up with, and how you came to that. Also, discuss it with your faculty members. If you have any questions about differential diagnoses, because they are so important, and it's really important to gain a good understanding of what this is and how you develop one. How we formulate a diagnosis. We don't want to rely on the classic symptoms of a disease because clinical variation, it varies all the time. And for example, with the strep throat, I have especially young children who will come in with complaints of a stomach ache, and that's it. I look in their throat and it's terrible. I test them, they're strep positive. I know through my experience that the most common symptoms of strep throat are headache, stomach ache, fever, and sore throat. One or all. Stomach ache is one of those. And children may not have the verbalization to connect that they have a stomach ache and they aren't eating because of their throat hurting. So we have to think outside of the box in that. We also, as providers, need to constantly learn. If we're going to be practicing providers, it is our obligation to have an understanding of the clinical presentation, the most current evidence-based guidelines and practice guidelines for the treatment of health conditions. So we need to stay current. We always must learn. So the learning process never ends. It won't end with your graduation. You need to consider um, ongoing education throughout your career. And again, this talks more a little bit about the current guidelines, but I'm focused more on differential diagnosis. We'll go into these things in greater detail as you move forward in the class. I hope this short video has helped you gain some understanding of a complex topic. The development of differential diagnosis is something that you will use throughout your career, not only in school, but as a provider as well. And understanding the aspects of how to develop one, or the concept of a differential diagnosis, is so important. So in summary, remember, you gather all of your clues from the information the patient tells you, from the examination that you perform, and from the laboratory tests that you perform as well. You take all of that information and you come up with a list. You take those clues and develop a differential diagnosis with all of the information that you have, including your own knowledge. What is the most likely diagnosis? And list those. Every time you do an assignment in class, you should have at least a minimum of 3 to 5 differential diagnoses. And again, we'll go into that in a little more depth once you get there. But for our purposes in this course, I just wanted to really touch on differential, and so it wasn't the first time you heard it in another course of what exactly it is. So I hope this provided a little bit of help for you, and have a great day.